Thank you all for joining our webinar this morning. We will be talking about advancing solutions for provider directory improvement. Great. So again, I'm Randy Chapman. I'm the Director of State Relations with CAQH. I am joined by my colleague Soren Davis, who is our Senior Vice President for Industry Relations. I'm going to start off our talk today, and then Soren is going to come in later on in the webinar to talk a bit more specifically about some of our solutions for provider directory improvement. Just a few logistics on how to participate. Many of you, I'm sure, have participated in GoToWebinar sessions. We are recording this webinar, and as a participant, you will, of course, receive a link to the webinar once we're done. We are also able to take questions through this platform. So as you can see on the screen there, you should be able to type in a question for us. And at the end of the presentation, we'll be addressing all of those questions. But if you have any sort of issues or technical difficulties during the presentation, please feel free to type into that chat box, and we'll be sure to try to get those resolved. So just to begin with a little information about CAQH. We are a nonprofit alliance of health plans and health trade associations, and we work collaboratively to create shared solutions to reduce administrative burden in healthcare business processes. Our board membership consists of the organizations listed here on this slide, and they are the ones with whom we chiefly collaborate to help us identify pain points that exist between health plans and providers, and then move towards solutions on how to deal with those pain points. So these organizations give us a tremendous amount of input into the work that we do. In addition to these member plans, however, we have a very broad reach and market penetration. We work with nearly 1,000 participating health plans, hospitals, and other credentialing organizations. In addition to that, we have 1.5 million unique providers that also participate with our solutions. So, and we do call upon those providers as well to help in our collaboration as we develop solutions to deal with these business-related pain points. Our work is divided into 3 initiatives. We have our solutions, of course. We also have our core initiative, and then our explorations initiative. We'll talk about the solutions throughout this presentation, but I wanted to give you a little information on both core and explorations. Our explorations team is our research arm, and they focus on our annual index report. This report is where we track health plan and provider adoption of fully electronic administrative transactions. In that report, we also estimate the industry cost savings opportunity as adoption and efficiency grows. So that is a really important benchmark report that we have. This will be our 6th year of production, and we are expecting our latest index report to come out very early in 2020. So definitely be on the lookout for that. Our core initiative houses our operating rules and development and certification program. And that is where we are really focused on creating streamlining and interoperability between systems. So for example, there are a number of standards that exist for exchange of health-related information. But in order for systems to really be able to exchange that information most effectively, there need to be rules in place that all of the systems can follow. And our core team is focused on developing those rules. Core actually, though it is a CAQH initiative, they have their own board. It is a multi-stakeholder board, including health plans, providers, and provider organizations. So we do a lot of work overall in the CAQH space of really looking at, again, automation in processes, streamlining in processes, and creating efficiency in healthcare business process. And one of the main drivers behind the work that we do is really looking at the rise in administrative costs in healthcare. We are all in the health, in the health industry talking about healthcare costs in general, be they utilization costs or drug costs, but a huge part of that is also administrative costs. And as you'll see here on this slide, in 2012, the costs were nearly $500 billion annually. And so those costs continue to rise. And because of that, CAQH knows that there is a lot of opportunity to insert efficiencies that can help bring those costs down for health plans, for providers, for the industry as a whole, and that will ultimately benefit consumers. So one way that we focus on our administrative simplification work and ensuring that we can help contribute to decrease in administrative costs is focusing on provider data and the accuracy of that data. As we all know, data is the most significant commodity of our time, and it drives nearly every process we engage in on a day-to-day basis. Provider data in particular in healthcare is the backbone of many healthcare processes. So as you'll see here, when we talk about provider data, it's basically information about providers, about groups of providers, about institutions. How do we access those providers? How do we find out what services they provide? What are their health plan networks? What are the products in which they participate in? All of those things comprise the universe of provider data. It's important because it, again, helps facilitate everyday business, health business transactions, everything from claim processing to contracting and licensing, payments, referrals, directories, credentialing. All of these different use cases exist for provider data. And who uses it? Nearly everyone who's involved in the industry. So it's plans and providers, it's consumers certainly, it's regulators. Now each of these players may have a different way that they use provider data, but they're all using it. And its accuracy and quality is of utmost importance if we are to create, again, streamlining and efficiencies throughout the system, which can lead to lower administrative costs. So as you can imagine, though, there are a number of challenges that exist in provider data and inaccuracy. And those challenges exist both on the provider side and the health plan side. So depending upon who you talk to on any given day, you'll get probably an earful on what are some of the issues that we're facing as plans, what are some of the issues we're facing as providers. I'm actually at a health plan conference now and was talking with a health plan executive, and one thing he said was, oh my goodness, we have got to figure out how to get our provider data to be more accurate and more high quality and get to a source of truth on that. So it's something that, you know, if you talk about it, it certainly comes up, and it is an ongoing issue. But one thing that you'll see here on the provider side is thinking about, you know, they often have to deal with getting similar inquiries from many different health plans. And I call that one out because that's one of the spaces where CAQH has really been able to make some significant progress, particularly on the credentialing side. There's also issues with the way the data needs to be submitted and the types of questions that they're asking, and just a general lack of standardization there. On the health plan side, they often have to deal with provider unresponsiveness. That's usually a big issue with health plans. Incomplete information. The contact information for the provider is not correct. So, and the health plans are trying to ensure that the information that they're putting out to their members, to their consumers, is correct. And that's very difficult to do if they're not getting accurate information coming. So so another driving force behind our work at CAQH is the state's needs to respond to federal requirements. So there are two major regulations, legislation that have been passed on the federal side listed here that really have both been driving forces in the credentialing and directory space, in particular for states. I should say that CAQH is not an organization that lobbies or advocates for any particular position. However, we do monitor very closely legislative and regulatory changes, both on the state and federal side, that can affect these administrative issues that are important to our member health plans. And so here, the Managed Care Rule, of course, 21st Century Cures Act, both of those speak to the need for states to engage in streamlining their credentialing and directory process. Ohio, in particular, has been engaged in administrative simplification efforts. In 2018, the legislature there passed the Healthcare Simplification Act, which requires the Department of Insurance to prescribe a particular credentialing application to be used by physicians. That application is one that CAQH has developed. So we're really excited to work in partnership with Ohio to ensure that that the data, the provider data that is coming into the state for use is streamlined, and that we are ensuring a high level of accuracy in that data. And as we also consider some of the major issues around provider directory in particular, we have to start with what CMS has done to really try and quantify that challenge. The inaccuracies in data have garnered the attention of CMS, and over the past 3 years, they have conducted a survey of Medicare Advantage plans to determine the extent of directory inaccuracies. And as you'll see here, the results are fairly dismal and pretty challenging. Over the past 3 years, the average deficiency rate ranges between 40 and 50%, with the deficient locations ranging between 45 and 55%. So if you can imagine, as a consumer, if you are trying to find your healthcare provider, according to this data, you've basically got a 50-50 chance that that your provider is where your directory is saying that they are. So that, of course, is unacceptable, and is something that we as an industry need to make sure that we're paying attention to, and that we are trying to improve. Next slide, please. We also want to call out that this provider not at location piece that's the largest area of deficiency. So these specific issues include a provider not being found or being found not to accept new patients when in fact the directory stated that they were accepting new patients. We have issues where providers should not have been listed at a location, or there's an incorrect phone number or an incorrect suite number that's associated with the location. The most significant error that was noted in the CMS survey is with these location-related deficiencies, where the provider is actually not practicing at the location that's listed in the directory. Again, a huge challenge for plans and consumers especially. So we just want to highlight one way in which we are partnering and working with states to try and improve their overall provider directory quality. In Massachusetts, we're working closely with health plans. We're working statewide in Massachusetts, also engaging with regulatory bodies and with other stakeholders in the state to move towards implementing a fully collaborative solution around provider directory, and ultimately to reduce provider abrasion associated with directory issues. Now, Massachusetts is just one example where we've got a state-based, statewide health plan coalition with support from a state health plan association, providers, patient advocates, where we're all working together with CAQH to improve directory and data quality. So this has been a wonderful project and experience that we're working on, and we are looking to work in other states on a similar kind of project so we can ensure that eventually across the country we are alleviating these issues associated with data accuracy. And one other point that I also want to note, we very recently surveyed a group of physician practices with regard to administrative burden associated with responding to health plan requests to update data. And last week, we actually issued a press release and a white paper and outlined the following findings. So directory maintenance cost, provider practices on average nearly $1,000 per month. And nationwide, the cost to providers is $2.76 billion annually. Now, this cost is driven in part by the number of health plan contracts that each that each plan has. And that's over 20 contacts on average. The larger practices that we surveyed contracted with as many as 30. So, again, that just demonstrates on the provider side the level of burden that they are seeing. The other thing that we found in this recent survey, that when a single platform is used to verify and update the information that's associated with directory, with all of these contracted plans, the cost could be reduced by nearly 40%, or more than $1 billion for practices nationwide. So we're talking about real savings potential and a real high level of burden throughout the industry. And one of the overall conclusions that our survey found is that the administrative burden of maintaining this data for physician practices it really challenges and taxes their resources and ultimately leads to directory inaccuracy. So again, there's a lot of potential to make some positive change in this area, and that's what CAQH is moving towards. We look at all of these challenges, working with our member plans, and we know that standardization, streamlining, and simplification are ultimately the keys to developing solutions to address provider data management. So with that, I want to move and reintroduce my colleague Soren, who will talk a bit more in depth about the solutions that we have related to provider directories. So Soren, I'll turn it over to you. Thank you.
Thank you, Randy, and thank you all for being on this webinar. What I will do for the balance is really illustrate to you how CAQH is trying to address this problem with a real-world solution. Many of you are familiar with it, and we will review and connect up, as you saw from Randy's overview of what the industry as a whole is doing and what the major drivers are to improving directory quality and accuracy. And I will illustrate for you how we're approaching solving for that problem. Next slide, please. Okay. So I think most of you are familiar with CAQH from its work in provider data, specifically relating to the credentialing use case, providing that provider-reported data that is used in the. This is, in essence, the first step to get a provider credentialed for a network. We have had a solution for that problem for the past 15 years. Actually, it's more. The solution went live in 2002, so it's definitely more than 15 years. What's also interesting is because we have had so much time working on this and because we actually developed something that solved a real-world problem, there are currently more than 1.5 million unique providers using this system to supply their data. It's critically important to understand that, in essence, what's happened here is providers have embedded ProView into their workflows, and they trust it, they recognize it, and are responsive. You're going to see what the impact of that is shortly. At the same time, nearly 1,000 organizations are using ProView as their provider data source, most for credentialing, but more and more now for the directory use case, since CAQH determined that the best way to successfully address this problem was to leverage a solution that was already well adopted by the provider community and trusted by the provider community to be that point of entry and portal to supply the additional data needed for directory. What's also interesting to note is that a lot of the data that is needed for credentialing is also needed for directory. So our challenge was, how do we leverage a well-used and working process to now address a new problem that is provider data-centric? Next slide, please. Obviously, the original ProView model was very much a provider self-reported, a kind of one-way street. CAQH provided telephonic support for providers, but it was mostly customer service related. With directory requirements, it became very clear that we needed to have a more engaged process with the provider that included outreach that was initiated by us based on provider statuses. I think you all know, and as you saw in the earlier slides, the CMS audit results were key drivers, along with the requirements that were published around this. And one of those was to have quarterly outbound communications to providers to demonstrate that the payer has complied with the outreach. So we developed a process where we are able to meet that requirement and provide the necessary reports for plans to demonstrate compliance. But we also discovered that as part of that process, we needed to have outbound phone outreach as well. It was no longer sufficient to just have pure system communications. Now, what is interesting is that over time, we see less and less of a need for that, but currently, to ensure that providers are fully engaged and that we get the desired outcomes around directory update information, we've deployed now an outbound telephonic outreach process to drive provider behavior even more than ProView by itself did. Next slide. Okay. Now, as I mentioned earlier, ProView was originally a one-way street. Providers submitted data, we processed it, cleansed it, and then pushed it to the plans. For the first time, we have now made the system bidirectional. What that means, and it was necessary to do in order to address those CMS problems, is that we are now able to take information into ProView from an external source, in the case I'll be demonstrating here or discussing its plans, to be able to put in front of a provider what the plans have as data for directory for them. If you'll remember in Randy's presentation, while we had a 50% error rate over 3 years roughly, when you look at what the vast majority of the errors were, 66% in fact, it was driven by provider not practicing at that location. So it became very clear to CAQH, and by the way, our approach to this was really to take each of those error states and determine how can we improve the results that led to those errors. We need to figure out, first and foremost, obviously, how do we address the problem of a provider not practicing at the location. And we worked with plans, and what we very quickly learned was, and also providers, what we very quickly learned was that providers are really great at letting a payer know when they have a relationship at a new location because they want to get paid. What is also interesting is that they're not as diligent about correcting errors or correcting information that says I'm no longer practicing there, because in their minds they're not going to submit claims, so who cares? I don't have to deal with it. The problem for payers is that their data now is arguably stale and nobody is advising them that it needs to change. So what we've done is we've said, okay, the best way to address this is for a plan to submit their directory data to us. We will compare it to what's been reported by the providers. And if it matches, great, you have more confidence that it's the correct information. But if it doesn't, we will now serve up that mismatch to the provider or that delta and ask them, we have information from another source about you practicing at a location. Is this correct or not? And the provider can now accept, reject, or actually tell us they don't know. And that latter part is because we're finding that the person may not always know at the point of interacting whether or not that is an accurate location. They have to do some research. They may have to check as if it's not the provider responding on that. So what we've done is provided an opportunity for providers to now react to what is in a plan's directory file. If they add somebody, no problem, just click on it saying, oh, I forgot this location, let me add it. Or they can reject, and then we will ask for reasons for that rejection. No longer practicing, or potentially it's part of my group, but I don't see patients there, or I retest. So we are able to start to provide a more granular view of the relationship of a provider to a location. Next slide, please. So what we're finding is that there is a very strong response from providers on this. And this is very dynamic data. I think most people knew this, but we're starting to see the data tell us just how often there are updates. 2.5% of locations in our system we now see are updated every month by providers. Okay, 25% new locations were created this year in our provider file. These are fairly huge numbers when you blow them out to the population. And 10% of locations were archived. That means the providers removed them from their site as active locations. And we store this for the provider, so it's not like it goes away, but it goes into an archive status. Okay, this has worked very well and ties back to this notion of the providers are engaged with this process. Their behavior is such that they know who we are, they know what they have to do in ProView, so it has become easy for these providers to tack on this additional functionality because it's in a workflow they're familiar with. Next slide, please. Okay, so what are we actually seeing here as results? Now, not everybody is yet using ProView for directories, but we're having a lot of traction from folks. And what we're seeing is, in terms of implementation, we had 780,000 provider app location records processed for the participating health plans. On average, what we're seeing is that 55% of the provider record locations match what is already reported by the provider. The next bullet, though, is one of the most interesting. Of the gaps, 344 practice location records that were not matched, 63%, or 91,000, were rejected by provider, meaning that they said, no, I'm no longer at this location, or I don't practice at this location. We also saw a 23% rate saying, I don't know, meaning they'd have to do further research. When that is elected, by the way, that will be resent to the provider or reshown to the provider the next time they come into the system. So it's not a one and done on the I don't know. That will continue to push to providers until we get a confirmation either to reject or the last bullet, accept, which was at 14%. And as you can see, some of the reasons for it, I never practice here. Location is part of my group. There's a list, and we will be happy to share, of the different responses possible to why you're no longer there, or more specifically, why you may be affiliated with that practice but shouldn't be put in a directory because you may be reading tests there but not actually seeing patients, or you may cover for a colleague, things like that. The key insights which we found interesting was the high reject rate, okay, and 55% rejecting due to no longer practicing. We also were encouraged to see the low accept rate, that 14%, which means that providers were diligent on their own without prompting from CAQH to maintain complete profiles of their data. Obviously, 14% said, oh, I forgot to put this location in, and accepted what we showed them from the plan, but it's not a high percentage. And what we started to see as plans are leveraging this, a 20 to 25% accuracy increase in their data. And it makes sense because this squarely addresses that 66% error rate of remember the 50% error rate, 66% was provider no longer practicing. So for us to solve that, you've already started to address half of the error rate that we've experienced. Next slide, please. Now, we have been doing studies with plans because obviously a lot of folks have a need for this, but there's also, it's new, there's a sense of, what is the right answer? Does it actually work? So we worked, and we've had several since, but one more recent one has been a plan that prior to using DirectAssure for its directories, were going through their own process. And as you can see from the data between March 2017 and March 2018, this plan did 1.2 million phone calls outbound to try to get information. That's one of the key methods that plans are currently using to try to figure out, are their directories accurate and to be compliant. They discovered that those calls only produced modest directory improvements, and equally important is the process was very costly and not sustainable. Okay, and last but certainly not least, from a provider perspective, they started to get pushback from the providers because remember, this is a every 90-day outreach requirement. So the providers are starting to get frustrated by the inundation of inbound calls and touches, not only from this plan, but from other plans as well. So if you listen to Randy's earlier note about the multitude of relationships of a provider to a payer, multiply that by having to do that outreach every 90 days by each payer, the provider is going to get to a point where they're going to start to ignore, or worse yet, potentially just provide whatever answer off the top of their head to get out from under the burden. So clearly the current methodology used by many people is not sustainable or effective. The results we saw in this version where they started to use our methodology is an immediate bump up in data quality, less provider abrasion. They had roughly 20,000 incorrect directory records, which the plan was able to terminate using the location data. And they were able to replace their phone outreach with the outreach that CAQH is doing, because we're also aggregating the plans together. So the outreach that we do is on behalf of the participating plans. It's multiple plans. So there's less provider abrasion as a result of that. The net effect of this particular study was that the plan achieved an 84% directory accuracy rate. And while we still want to achieve even higher rates than that, This was viewed as very successful because it did a number of things. Obviously, it was more efficient, but also equally important and arguably more so, being 84% accurate moved you on the scale of not being a target in the CMS audit the same way. So the results were very promising, and what we've also learned is additional areas where we're looking to improve. Ideally, we want to achieve accuracy levels of 90% or better on directories. So we still have some challenges to address, but we're making good progress on that front. Next slide, please. It's what you're seeing here, and I won't go deeply into it, is a very high-level system flow of how the process works. Basically, as I said, the health plans provide data to us. The DirectAssure system compares it with what the provider has self-reported. The provider sees it, can reconcile any of the discrepancies, and that data is pushed back. And the plans can then, with greater confidence, because they'll now have an attested to piece of data, act on that by either terminating it, or if it is still do I need this provider? They do see patients, but it's sporadic. The plans can make more informed decisions on how to present that provider at that location to their members. Next slide, please. Okay, so actually we're doing really well on time. We'll have time for Q&A. So to summarize this, what the health plans that are using DirectAssure are continuing to do is to really filter their directories in their market with this process. If you looked at, and we didn't go into this, the focus of this presentation has been primarily on the big, provider not practicing at location, but CAQH has also tried to address the other issues around the telephone number not being accurate. If you looked, I think it was 14% error rate, something like that, on the phone number inaccuracy. We've also addressed that. What we found in our research in that scenario was that the way you ask the question is really important. When providers receive a request for a phone number from a payer, they typically think of their relationship, their business relationship with that payer, and so will often provide an administrative number because the thinking is if they're going to contact me, that's the number they need to use to get to my administrative staff. The problem is when the plan uses that number and publishes it, because that's the number it got from the providers, and a patient tries to call and they're now suddenly on an administrative line, they'll be told this is the wrong number, you don't call here for an appointment. When CMS does that in an audit and gets that response, that's an error in their book. So our response to that was looking at our data and saying, you know what, if we ask the question more clearly as to what we want, in essence the question being, what is the phone number that a patient can call to make an appointment to see you? Okay, that is a very clear instruction. What we find is that providers definitely want to supply the right data, but because of the historical business connections, there can be confusion around what data is being supplied for what purpose. So that's another example of some of the stuff we've done. On the addresses, which there were two buckets, a wrong suite number, bad address, I think that also accounted for collectively about 17% of the errors. We've now also deployed USPS address validation, and we put that in front of the provider so that they can see what the standardized address is, and it's set as the default, but the provider can choose to override that and put in a different address. Typically that occurs when there's a vanity address associated with it because USPS does not recognize those, but providers want it. So we always give the provider the ability to override something, but by using third-party validated sources like USPS, we start to improve the data quality around the addresses as well, and we find that most providers are accepting the USPS validated data. So what we're seeing is more and more plans as this rolls out are starting to embrace this as a solution. Obviously, it's results driven. So we've seen a great uptick in this. and that process has been moving along really well. Now, I think I'm going to talk about one other solution we have related to this, and that's CAQH ProView for groups. To set the stage for what this is, ProView was originally built as a credentialing system. So while we have the 1.5 million providers in it, there are groups out there that are delegated from a credentialing perspective. So they have needed, and the way they communicate with plans is not necessarily through ProView from a credentialing perspective. They didn't need it. But for directory maintenance, they still have to supply this information. This has been typically done, next slide please, through a roster process. The current model has been each group with each plan has its own roster. Those can often be what the group has created. Sometimes it's what the plan creates, but it is basically a one-to-one match, and there can be a lot of discrepancies between them. And candidly, it is a very non-system-based approach. So your problems are those disparate roster formats. Also, this is basically emailed around because they're often Excel spreadsheets. So it's not the most secure way of sending the information. Okay, there are varying reporting intervals to manage, and because it is a relatively manual, human-driven process, there are often back and forth emails and calls to check status or to clarify the data. And because it is a manual process, there's no ability to leverage technology to correct obvious errors. Those typically are omissions or illogical responses to a question. So we try to address that as well. Next slide, please. And basically, we applied the CAQH philosophy you saw earlier, which is really around standardizing an approach, trying to automate it, and to really eliminate all of the redundancies and inefficiencies. So single standard roster, a secure data storage and exchange. We now are, in essence, eliminating having to email that. Auto notifications when things need to be fixed or done again, because that flow of information is quite constant. There is obviously greater data accuracy and transparency in the process, and the reduced manual work and delays. Plus, it allows more automation, both from the payer side, which is where they're consuming the data, but also for the providers that have systems already in place, because in essence, if nothing else, we've provided a standard roster format that can be used by everybody. And again, as all CAQH solutions are, they're free to the providers. The investment we want from the providers is the time and diligence to do the process and to do it right. And I'm happy to say we've been quite successful with that. Next slide, please. Okay, so right now, through this process, we've seen improvements as well. And examples are, we've already eliminated 500 duplicate practice address removed from it. Unique titles and provider specialties converted to industry standard. We have 1,000. Similar to what we see in the ProView DirectAssure model, we're also seeing similar results in the ProView for Groups roster process. 26,000 incorrect addresses removed through data quality controls. And also, again, starting to standardize, so invalid taxonomies, things of that type are being addressed. This is also fairly new, but also very exciting to the groups that have historically been working with these rosters. And the plans themselves are also very happy with this process because it is addressing some of the inefficiencies and errors that the existing process has created. Next slide, please. Okay, so in summary, you've got increased file accuracy and completeness of self-reported provider. We're reducing errors with assistance of external validation of key elements. The USPS component is the example. We are in the process of deploying additional third-party primary sources to validate data so that while self-reporting is at the heart of what we do from the provider perspective, we want to leverage third-party data as appropriate to improve the quality of those self-reported responses and to highlight areas of focus for the providers to address specifically known problems or discrepancies in their data. Obviously, the staffs love this on the provider side. We've gotten extremely good feedback, and a lot of our design was based around that user experience to begin with. And I can tell you, because I think we've posted some of the responses, they love that there is reduced provider abrasion. And for them, that's all about how do people ask me the question once, let me respond to it, and then I can distribute it to many instead of how often it's been happening, which is each organization is asking me the same question individually and often slightly different, which also produces problems. And last but not least, it also lowers the overall administrative costs for doing this. Providers, obviously for them, the costs are the effort on their side to do this, and for the payers, it's the same, plus the general costs around how do I fix errors as a whole. So through automation, and a lot of the plans now are deploying and working on getting the data coming out electronically, not having people review, but rather going into their own internal systems and trying to get as much automation in the process as possible. Next slide, please. So we're at the end of this, and I think we've left enough time in this discussion for Q&A. Sam, I'll turn it over to you if you can guide that.
So are the lines open for questions? Are we, is everyone able to, I think I can just read the questions out actually. Thank you. Soren, thank you so much for your presentation. And we do have a number of questions that have come in. I think all of them are for you. So get ready. The first question is, do we have any data on the response rates for attestation out?
Do we have any? Say that again. I'm sorry, I missed the beginning. It cut off.
Yeah, sure. Do we have any data on the response rates for attestation out?
We do. Our attestation process, and it's a complex. The short answer is yes, we do. We will supply that data. I don't have it off the top of my head. I do believe it is very high. I think we've had like 1.24 million, and again, I'm going from memory here, providers attest to their records in the last 120 days. So that would give you the ProView attestation cycle is a 120-day cycle. We do comply with the 90-day outreach from CMS. So those are, the outreach is not required to have an attestation linked to it, although we will drive always to get those. That was the outreach that I referenced from a telephonic perspective. But right now the data I do have is based on, I believe it's 1.24 million providers have attested to their records in the last 120 days. But we will confirm that for you.
Okay. Great, thank you. Another question is, how do we measure the percentage of directory accuracy?
How do we measure it? I mean, people will conduct mock CMS style audits, if that's what you're getting at. How do we determine whether or not we're moving the meter on success? If that's the question, that's generally how you determine whether or not you're improving the data.
And
you have
so,
to confirm it.
Sorry. So that might be the plans themselves, or the participating, whatever organization is using a directory solution, they would have their own kind of internal survey that may be similar to what CMS did. Is that Is that usually
That's generally how people validate whether or not they're seeing an improvement by using the tool. Because what they're trying to protect against is obviously having a bad CMS result in the next round of audits. So that's the easiest way to do apples to apples and measure your impact. CAQH is also looking at this independently because we can roll up a lot of this data ourselves. But the proof is always with the plans testing it with mock audits.
Okay, makes sense. Thank you. So another question, does CAQH track the date that a provider left the practice?
Termination
is there any
date.
Yeah.
I don't know the answer to that. I want to say yes, but we need to validate it.
And let's see, another question that's come in. Does the process track the billing tax ID that the provider uses?
If we mean the TIN number, the answer is yes.
Would think so. Okay. The question just reads billing tax ID, but I would think that's the PIN number. Let's see. And Soren, do you have, this one might be. How do you ensure that ProView and DirectAssure are staying updated with the latest regulatory provider data element requirements? So I can take that one initially, Soren, if you want to add, that's fine.
Yeah, my answer is Randy, so yes, please take it.
Right. So yeah, so that would be, that is a lot of the work that I do with CAQH, is making sure that as there are regulatory and legislative changes, that our solutions team is informed of that, and we're ensuring that our solutions are keeping up with those requirements, because they can, of course, change. And so we want to make sure that we are up to date with the latest in terms of regulatory and legislative requirements. And again, that's on both the state and federal side. Okay, so this question gets to if we've got a provider that is rostered with, for example, 3 different plans, and let's say in 2 of the plans, there are different phone numbers or different addresses. There's some kind of different location information. How do we reconcile that or validate that? Do we send that back to the provider to say, hey, Dr. Jones, you're listed with A, B, and C, you're rostered with A, B, and C plans, but you've got different addresses on B and C. How do we reconcile that, and then how do we communicate that back to the plans once we've reconciled it?
Okay, so to me that's a two-parter. One, if it is actually the same location with an address error, a wrong suite number, a bad zip code, something like that, we run this through the USPS and standardize the address that way, and then have the provider acknowledge it through the attestation, and that gets pushed back to the plans. If the question is that the provider has relationships at multiple locations, but not every location is connected to every plan that the provider has a relationship with, the way we approach that is that per plan, we identify to the provider what plans are using what addresses. So the provider not only sees address discrepancies, but also sees the connection to the plan. That's particularly important, and I didn't mention this earlier, but that's also how we get at, do you accept new patients? Because that is potentially a plan level comment at the location. So the provider is able to see by plan the locations, and then also indicate at that point whether or not they're seeing new patients for that plan. We do not have that ability yet at the product level within a plan. We are looking at that, but the concern, candidly, we have with that is twofold. One is providers really have the ability to answer that question at that granular level. It's a contracting question, and certainly the plans have the contract. So we've been looking at that. And the second problem with that is that potentially we would be inundating them with information. If the average provider has, 10 to 20 relationships with payers, and if each relationship has, 5 products, you would suddenly have to present a matrix that could be daunting to the providers. So we're conscious of it. We've been working on that, but right now it's at the plan level, not the product level that we're addressing. Hopefully that helped. Yeah.
Yeah. I'll just say this, just a couple things kind of logistically. The webinar will be recorded, and you all will be receiving a link to the recording in about a week or so, if not before. And also, if you have a follow-up question that wasn't addressed or that you need some additional clarity on, please do feel free to reach out to me or to Soren. Our email addresses are noted there on the screen. We've got a couple more minutes and a couple more questions I want to get to. This one I think is for me, and Soren, you can add color if you need to. How many states recognize the CAQH application? So we have 13. There are 13 states that use the CAQH application as a standard credentialing application in their state. There may be some nuances to that depending upon the state, but there are 13 that do recognize the CAQH application as a standard application for their state. Next question, Soren, this is for you again. What is the output of an accurate provider directory? Do the health plans receive a report about directory accuracy, or is there capability to provide some kind of outlook, I guess, or kickback of information to the plans online or other forms?
Yeah, we are not summarizing for the plan their accuracy improvement per se. What we're giving the plans are the provider responses to the question. So when a provider eliminates a location, based on us having presented it from the payer, and they're saying, no, I don't practice here, I've left this practice, that information is pushed back to the plan. The plan needs to then take its action internally, and every plan has slightly different business processes around how they deal with this. Some also layer on top of it network adequacy concerns. So there isn't like a generic CAQH is declaring for, this plan what their accuracy level is. Each plan determines that on their own based on where they were originally and in taking in the data they're getting from us and then doing their own internal audits around data quality, seeing what that improvement is. What we've shown you is, I think, earlier an example of one case study where the results that the plan recorded were 84% accuracy. And that's generally been what we're seeing in that neighborhood. It obviously varies by plan, but that's generally what we're seeing at this point.
Okay, great. And it is right at 12 o'clock. So I want to certainly be respectful of everyone's time. We do have a couple of additional questions out there. So we can connect back with the folks who asked those questions offline. Again, please, anyone who's on today, do not hesitate to reach out to either Soren or myself. If you've got follow-up questions, we're more than happy to talk with you. One of the things that CAQH really prides itself on is being a resource to the industry and to health plans, to providers, to those of you who are interested in moving the entire industry forward towards a more simplified and efficient process for handling provider data. So with that, I'll close. Soren, thank you so much for joining me today, and thank you to my colleagues at CAQH who have helped with the administration of this webinar. And with that, I wish you all a great afternoon. Thank you all very much for attending.
Thank you all.